Hey everybody, Dr. Reviso here. In this video, we're going to talk about the lymphoid tissue, and this is a new unit, so we're just starting immunology here. We're really going to start with the bare bones basics in this video, and then we'll build up on some of the more difficult concepts to grasp. But in this video, we're primarily going to just talk about, some basic types of lymphoid tissue. We'll talk about some of the primary lymphoid organs, and then towards the end of this chapter, we'll talk about the secondary lymphoid organs, most notably the spleen and the lymph node. Like I said, we're just going to start with the basics here. So when we're talking about lymphoid tissue, the way to organize this in your brain without, going back to your histo and having to know all of the little details, the big thing here is to just organize this into primary and secondary types of lymphoid tissue. And so the primary types, the two big ones being the bone marrow and the thymus, which we'll talk about here. And, the thing to remember about the primary lymphoid tissue, that's primary because this is where your lymphocytes are usually going to form, particularly in the bone marrow, okay? And then we're also going to have lymphocyte development. So in the bone marrow, think B for bone marrow, B for B cells, primarily development of B cells in the bone marrow and development of T cells in the thymus. So we'll talk about that in a second. And then in terms of secondary forms of lymphoid tissue, the big two here are going to be the spleen and then the lymph node. And we'll talk about each of those in a little bit more detail in the upcoming video. But the idea here is these secondary tissues are not necessarily creating the lymphocytes, right? Like you'll see in the bone marrow, but instead this is where we're going to have lymphocytes activated, antigens that are coming in, or antigen presenting cells that are coming into the lymph node, for example, to cause activation of B cells, T cells, and eventually proliferation of those cells. Okay, starting with the primary lymphoid organs, we're talking primarily about the bone marrow and the thymus. And remember, the bone marrow, the big thing to remember here is that this is where these cells are going to form. That's where we're going to turn hematopoietic stem cells into cells of the lymphoid lineage. So this process, again, is happening in the bone marrow. Okay, so this is going to be happening in the bone marrow. We're going to start off with a hematopoietic stem cell. And so these cells, they can differentiate a couple different ways. Two of the big categories here is going to be the lymphoid lineage and the myeloid lineage. Now, in general, the lymphoid lineage is what we're primarily focused with when we're talking about immuno. Okay, so in this unit, we'll primarily be on this side of the diagram. When we go on to hemonc, right, we'll talk more about some of the myeloid lineage cells here, okay? But for this video especially, and this chapter in general, we're mostly going to be talking about lymphocytes. And so the lymphoid lineage forms lymphocytes. And the three big ones to remember here are going to be B cells, T cells, and NK cells. These are natural killer cells. Okay, and now the natural killer cells in general are going to be part of the innate immune system. Okay, so these are going to mostly be innate immune system. And you'll see that the B cells and the T cells are going to be part of the adaptive immune system. Everything here, by the way, is pretty much all also going to be part of the innate immune system. Kind of confusing, but again, these are just ways to organize these in your brain, is that you can see that all of these cells come from hematopoietic stem cells in the bone marrow. And so they're all going to be formed initially in the bone marrow. That's the important part. So the B cells and T cells both come from bone marrow. Where they mature is what's different. So the B cells are going to mature in the bone marrow, right? So they're going to stay in the bone marrow and mature in the bone marrow. Remember, B for B cells, B for bone marrow. That's where they're going to mature. Now the T cells, they're going to be formed in the bone marrow, but they mature in the thymus. So T for T cell, T for thymus. Okay, but remember that all three, the B cells, the T cells, and the natural killer cells, all form from hematopoietic stem cells that undergo into the lymphoid lineage. And this is stimulated by interleukin-7. We're going to talk about this in great detail to come. And again, the big point here, B cell proliferation and maturation happening here in the bone marrow. Now the second major primary lymphoid organ is going to be the thymus. So I put on here a couple of the big things to know. Now in general, there's a lot of information you can talk about when you're talking about the thymus, but I just want to remind you again, we're just kind of focusing on what's the big high yield stuff that we have to know. First thing that I would say, just to go back to your embryology, because we kind of already hit this a little bit in some of the previous videos, but remember the thymus is derived from the third pharyngeal pouch. Remember, your pharyngeal pouches are associated with endoderm. So pharyngeal pouches, remember, these are going to be associated with endoderm. It's important to remember this because remember, in DeGeorge syndrome, we have some abnormal development of the third and the fourth pharyngeal pouch, right? So these pouches don't form correctly in DeGeorge syndrome. So you can imagine, because the thymus comes from that pouch, if it doesn't form correctly, you're going to have deficiencies with the thymus. And so this is why with DeGeorge syndrome, we classically see this thymic aplasia, right? The thymus doesn't really form the way that it's supposed to in DeGeorge syndrome. And this has implications in the lymphoid system because remember, the T for thymus is for the T of T cell maturation. Okay, so if the thymus isn't working, then the T cells are not going to mature like they should. Remember, this is where the T cells are going to come to mature, and we're going to talk about that process in great detail. But there's a selection process essentially that's going to happen in the thymus as these T cells prepare for maturation. So again, if we have a disorder where the thymus isn't working, or we have thymic aplasia, we're not going to get T cell maturation, and so that's going to have some pretty significant consequences, as we'll talk about in the upcoming videos. Also, a little bit lower yield, but it's important to remember the thymus is an encapsulated organ. It has a pretty fibrous, thick capsule, as opposed to some of the other tissues like the spleen, which is very thin. And in general, you'll occasionally get histology images. The thymus isn't as high yield as compared to like the lymph nodes, for example. But just one thing to note here about the thymus. So in general, remember the cortex is going to be darker staining. So we're going to have a higher concentration of lymphocytes out here. So this whole area out here, this is going to be your thymic cortex. And then in the center, you're going to have the medulla, which is going to be lighter staining. In general, the cortex is going to be more superficial. For these lymphoid organs, the medulla is going to be deeper. And the one classic histologic image that occasionally comes up here for the thymus is going to be these Hassel corpuscles. Now, they don't really have, a very clear function. So there's nothing to really remember in terms of, physiologic function with these Hassel corpuscles. But the thing to remember is that, number one, they're located in the medulla, and just kind of recognize their appearance. When I see this kind of whirling, swirled appearance, I'm almost thinking of what you see with keratin pearls in a way. They're not completely related, but the representation of these Hassel corpuscles, that's kind of what it reminds me of in a way. And so that's kind of how I would organize it in my mind. Now, we already talked about DiGeorge syndrome, thymic aplasia, because you have abnormalities in the formation of the third and fourth pharyngeal pouch. You can also see severe combined immunodeficiency, is where you're basically wiping out your B cell and T cell population. And again, I'll talk about this in much greater detail to come, but this is also classically associated with thymic aplasia. The other big place that the thymus comes up is with thymomas. And myasthenia gravis, if you ever have a question, like we talked about in the neurology section, where you have a patient that has myasthenia, or very classic symptoms of myasthenia, right? You do an ice pack test or something, and their symptoms improve or whatever it is, or they have some fatigable weakness, and you're thinking myasthenia. In those situations, if you have solid evidence for myasthenia gravis, usually they'll say, okay, what's the next best step? CT scan just to look for a thymoma, okay, which would be some kind of mass, potentially something that's perineoplastic, releasing antibodies causing myasthenia, or causing worsening of symptoms potentially from the thymoma. Okay, so that's why we look for those. Now, what I want you to remember, and gets very confusing, especially for your first couple of years of medical education, when you look at, a pediatric x-ray here, okay, so you might be saying, what is going on with this patient? Why is there this mediastinal widening? If I see mediastinal widening like this in an adult patient, I might immediately start to rattle off my differential. Is this an aortic dissection? Does this patient have anthrax, right? If I see some mediastinal widening like that. But if we're talking about a pediatric patient, particularly a patient that's like an infant, normally they're going to have a prominent thymic sail sign, is what it's sometimes called. In general, they're going to have a larger thymus. And so this is actually quite normal to see this very wide thymic tissue here, believe it or not. Now, as we age, what happens is over time, that thymus starts to involute a little bit. So that thymus is going to get a lot smaller, and it's going to get replaced with fatty tissue. And that's completely normal. That's what's supposed to happen. We shouldn't see massive mediastinal widening in a patient that's 40 years old, for example. In those situations, we might be going through our differential. Potentially, if they have myasthenia, we might be thinking thymoma. Okay, so just kind of keep that in mind. It's important to recognize the age of the patient you're dealing with when you see some of these images. All right, so let's talk a little bit about the secondary lymphoid organs. So the first one we'll talk about here is the spleen. When I think about the spleen, I like to organize it into two categories. I think about the white pulp and I think about the red pulp. Now, what I want you to do is just to think about how you would get into the spleen, right? If you were a cell or an antigen potentially, you'd come in through an artery here, okay? And you'd eventually kind of go off into one of the arterioles. And eventually, as you come out of this arteriole, the first thing you're gonna hit here is gonna be this white pulp. Okay, so you can see this white pulp is surrounding the arteriole. Okay, so that's the important thing. Now, what is in the white pulp? So there's two kind of major things. We got B cells and we have T cells. We have them both. The B cells are going to be in follicles. When you hear follicles in the lymphoid system, right, you're going to think about lymph nodes, you're going to think about the spleen. In both cases, follicles represent B cells. Okay, so that's going to be pretty consistent throughout. So remember that. Periarteriolar lymphatic sheaths, if I took a cross section here, let's just say that I, blowed this image up, right? I blow this image up and I have, I'm going to do this in kind of 3 dimensions. Here's my arteriole coming in. And then, maybe around this arteriole, I might have a bunch of T cells. Okay, let's just put a bunch of T's here. So here's a bunch of T cells. They're all kind of surrounding this vessel as it comes in. And remember, this whole thing around this arteriole is going to be surrounded in white pulp. Okay, so this is all going to be white pulp. So this whole area here, it's all going to be surrounded in white pulp. And that area around the arteriole, remember it says right, around arteriolar lymphatic sheaths. It's almost like a sheath of T cells surrounding that arteriole. The whole purpose of that is if I have antigens coming in, right, those antigens can be recognized by the T cells. Okay, so that's the point. That's why they're there. So it's a dense lymphoid tissue surrounding the arterioles as you come in. Again, all in the white pulp. And like I said, we also have follicles there. Those follicles are going to have B cells. What are the B cells going to do? These B cells essentially will be producing antibodies. Okay, and so when we talk about things like, IgM, right? This is an immunoglobulin M. It's a type of immunoglobulin. IgG, right? IgE, all of these things, right? B cells are going to be producing those, right? These are going to be antibodies. We're going to draw them like that most of the time. But some of these, like IgM, they're going to have really, big structures, okay, potentially. They're all shaped a little differently. We'll talk about that. But the point here is that the B cells will be making antibodies. The T cells here are going to be recognizing some of these antigens coming in, and we'll talk about all the details of what they're going to do. Okay, but for the purposes of this video, white pulp, follicles, B cells, periarteriolar lymphatic sheaths, T cells. Now, what happens when you go from the white pulp to the marginal zone? Okay, so the marginal zone, first of all, what is the marginal zone? Marginal zone is the area between the white pulp and the red pulp. So it's kind of like this really smaller zone here. I'm just going to put marginal zone here. And, if we were to kind of put a line out here to represent it, you can see here's all white, here's all red. And so it's this area kind of right between the two. Okay, so that would be your marginal zone. Okay, and this is a gross oversimplification, but it's really all you have to know in terms of this. Now, the marginal zone, you just have to remember there's a lot of phagocytic cells there, right? The antigen presentation from things that are coming from the blood can happen here. You can have macrophages or antigen presenting cells that can digest bacteria, foreign substances, present these to nearby lymphocytes. That's really the extent of it that you'd have to know here. Now, what about the red pulp? Okay, so you can see the red pulp is all this area around the white pulp, again, separated by the marginal zone. Now, red pulp is kind of easy to intuitively make sense of. So the red pulp is going to manage a lot of the red blood cells. Okay, so the arterioles are going to come in and they're going to go into these sinusoids. Okay, so let me kind of draw this out for you a little bit. So I'm going to use this pink color here. So let's just say this is my red pulp back here. Okay, again, the marginal zone is going to separate the white pulp and the red pulp. Red pulp is going to be back here, but think of your red pulp as having, maybe like more of a web-like characteristic shape. At least that's kind of how I think about it. Now, the reason I think about it like that is because the red blood cells that come out through here, right? The red blood cells that come out through here, they're going to have to traverse that red pulp and the sinusoids that go along with it. And they're going to have to come out of the other side. So take a look at this, right? So if you were just coming in here, right? If you were a red blood cell and you came in through this arteriole, you're going to have to traverse the white pulp, traverse the marginal zone, and get into this red pulp. And from this red pulp, you would eventually get to a venule, and you'd find your way out and eventually get into the portal circulation, right? Through the splenic vein, etc. The point is, though, is that you're coming into this arteriole, you got to traverse this red pulp. Okay, so if you're a red blood cell, you got to get through the red pulp. And the red pulp is going to have a lot of these kind of sinusoids that are made essentially to try to trap the old red blood cells. Okay, because initially, right, you have a red blood cell that has a characteristic shape. But over time, that red blood cell is going to get very rigid and it's going to lose its flexibility, okay, and lose its shape. And so it's going to be unable to traverse through these sinusoids eventually. What happens is if that's the case, these macrophages, right, they're going to come up and eat up that red blood cell. The concept, though, is, let's just say you had an infection here of this red blood cell. Okay, so you had some infection in that red blood cell. Well, if we had the ability to eventually destroy these red blood cells because maybe the infection destroyed the structural integrity of the red blood cell, right? So the sinusoids would pick up on that. Macrophages would digest this red blood cell and destroy this red blood cell and potentially the infection along with it. But if you had a patient that did not have a spleen, you wouldn't be able to digest these red blood cells, number one. And so you're going to get very characteristic red blood cell shapes, which we'll talk about in the hemonic section. I don't want to get too off track here. And the other thing, though, not only will you get very characteristic red blood cell shapes, but you'll also have difficulties, if you don't have a spleen, in clearing infections that attack red blood cells, like malaria. If we're talking about a patient that's from a more underdeveloped country where, malaria is endemic, that's usually how they'll tee up the question initially, right? That's going to be very classic. If they have their spleen removed, that's going to be a problem in a lot of these patients. What about in the U.S., northeastern U.S.? What are you thinking about? right, of infections of red blood cells. You might be thinking about Babesia. Things to keep in mind. If you have a splenectomy, my point is, don't just go to encapsulated bacteria. That's the classic kind of old school way that's presented, but also remember malaria and Babesia exposure as well. Now, let's just take a step back here. I explained this part, but why, if you had your spleen removed, would you be at risk of these encapsulated bacteria? Okay, so let's clean this up for a second here. Okay, let's just imagine here I have some bacteria. Okay, so here's my bacteria, and normally I have some antigen presenting cells here in my body, and these antigen presenting cells, when they see this bacteria, they come in and they try to eat up this bacteria. Okay, so that's essentially what they would do. They undergo phagocytosis, present the antigens, right? And we'll go into all the details on that. In a perfect world. However, there are things that bacteria can do to prevent that from happening. One of those things that's very classically asked about are going to be these capsules. Okay, so a bacteria can have a capsule. Now, the three classic ones to know of that do this, the biggest one, number one, strep pneumo. By far, that's the important one to know. If you can only know one. Haemophilus influenza type B, Neisseria meningitis, those are also important. So they have a capsule. What this capsule does is it can prevent this antigen presenting cell from being able to digest it because it has this rigid capsule on it now. Okay, so the antigen presenting cell needs a way, essentially, to try to digest this bacteria now, right? It can't do it through just phagocytosis alone. So what can happen is, right, we have antibodies, right, in our blood, right? Let's just say we have some IgM antibody here floating around, and maybe this IgM antibody binds to the surface of this bacteria, okay? And in doing that, now this bacteria is essentially tagged for destruction. So now certain antigen presenting cells can bind to the other portion of this IgM. They can bind to this, and that will give them the signal to say, hey, you can digest this bacteria. Okay, and now the antigen presenting cell can engulf our bacteria again. Okay, so let's say this is my antigen presenting cell. Now the antigen presenting cell can engulf the bacteria because there was the IgM, there was the antibody on the surface. The other thing is, when you start tagging these bacteria, you open the door for complement. Okay, so you can have some complement floating around in the blood, particularly C3b, right? That will bind here and it would help destroy this bacteria eventually, right? So that's the concept. The concept is, if you have antibodies like IgM, they can bind to the surface of bacteria, target it for destruction. If you don't have a spleen, that's a problem because the spleen is very important in antibody production. In fact, nearly half of the body's total immunoglobulins come from the spleen. So if you don't have a spleen and you have encapsulated bacterial infections, right, that's a big problem because you can't tag that bacteria for destruction. And so again, if you don't have a spleen, you want to be very cautious with strep pneumo, Hib, Neisseria, so you vaccinate these patients because we have a vaccine for each of these, right? All three of these we have a vaccine for. The point is that you can vaccinate these patients because they're at increased risk of infection with encapsulated bacteria. Now, in what situations would a patient not have a spleen to begin with? Well, trauma is a big one. Particularly, think about patients that have mononucleosis, EBV infection, younger kids, usually adolescents, 16, 17 years old, right? If they have mononucleosis, that spleen's at risk for rupture with trauma, right? So remember, left upper quadrant between the 9th and 11th ribs usually is the area we're talking about. Now, hereditary spherocytosis, we'll talk about this on HEMONC. What's the treatment for it? Definitive treatment, splenectomy, right? You take the spleen out, but then these patients are at risk, right? You got to make sure they're vaccinated. Sometimes this vaccination schedule is actually even more aggressive than a patient that didn't have a splenectomy. And the same is true for sickle cell disease. In sickle cell disease, these patients can have a spleen physically, right, in their body, but it doesn't mean that it's working correctly. Sometimes all of these sickle cells can cause there to be decreased filtration, decreased perfusion to the spleen so that it eventually just doesn't work. It can atrophy. Okay, so that's something to keep in mind. Also keep in mind that a lot of the platelets are stored in the spleen and can also be filtered in the spleen. All right, let's talk about the lymph nodes. So the lymph nodes are probably the most important secondary lymphoid organ overall that you're going to get asked about. Now, the lymph nodes are broken up again into three categories. Again, cortex, we can think of that as being the more superficial layer, medulla, the more deep portion of the lymph node. And the paracortex is kind of like the inner cortex, so to speak, of these lymph nodes. Okay, so we'll talk about all three of these. And again, it's important to know, like previously, where are the B cells, where are the T cells? Okay, so again, B cells, we already said, when there's follicles, there's B cells, right? So the B cells are going to be located in the follicles, just like we saw with the spleen. Now, the difference in the lymph nodes is you do have to keep in mind there's primary follicles and secondary follicles. Okay, so this is actually one of those topics that, it seems very detailed, but this is something that comes up quite frequently. So here's a lymph node. The thing that I want to call your attention to in this lymph node, two things. So the first one here, right, you can see that there's this kind of circular structure. There's a difference in the color gradient between, this darker purple and this lighter pink purple color here. This circle here, this is going to be a primary follicle. Okay, so this is going to be a primary follicle. And I'll talk about what that is in just a second. And we also have secondary follicles. Okay, so, this structure here will be a secondary follicle. So what's the difference? So the primary follicle, you can see that it has a pretty dense, dark color primarily around most of it. Okay, so that dense color is going to represent more lymphocytes, right? So this is going to have more lymphocytes that are kind of just sitting around dormant. Dense amount of B cells that are dormant. They haven't really been activated. Okay, that's the concept. That's why they're not moving. They're sleeping, so to speak, if that's an easy way for you to remember it. Now, the secondary follicles, on the other hand, you can think of these follicles as being activated. So I'll talk about how this whole process works in just a second to clear this up a little bit. But the secondary follicles, again, are going to be the ones that are activated. And so when they're activated, think about them moving around. So if you were trying to take a picture of them, right, on this slide, it'd be hard to pin one down, right, because they're moving around so fast. And so you don't get that dense, dormant appearance where you have really darker staining like you see with the primary follicle. Instead, you kind of have this very lighter color in the center of your follicles, and that lighter color is sometimes called the germinal center. Okay, so we can call this the germinal center of the follicle. Okay, and so those B cells that are in the middle that stain lighter, those B cells are undergoing isotype switching and being activated. And remember, what is isotype switching? Isotype switching is essentially where you're taking your standard IgM antibody, okay, which we'll talk about, that's going to be produced initially, and you can change the heavy chain of this antibody to make it IgG, you can make IgE, you can make IgA, okay, we'll talk about all of this, like I said, in great detail. And you do this by changing the heavy chain. Okay, so the heavy chain is going to allow you to change, the structural integrity, so to speak, of the immunoglobulin. However, what you're going to notice on all of these is that the light chain is the same. So the light chain is essentially what is antigen specific. Like I said, we'll go through this in greater detail, just introducing it here, but that's the concept. So we have activation, antigen switching. There's a lot of things going on in the secondary follicles. They're staining lighter because we can't quite pin down those B cells. They're just moving, they're being activated, and that's just my intuitive way of remembering that. You can imagine, when would you have more activity in these secondary follicles? Well, if you had an infection, right? If you had an infection, B cells are more likely to be activated because there's an active infection, and so you're probably going to see more germinal centers, more secondary follicles. If a patient, for whatever reason, had a disease where they would have a deficiency in maturing these B cells, for example, X-linked A-gamma globulinemia, what's the issue here? Well, you can't make mature B cells. If you can't make mature B cells, right, we might not have follicle formation. So we can see a significant decline in the number of follicles just in general when we have X-linked A-gamma globulinemia, or SCID for that reason. But this classically gets asked about with X-linked A-gamma globulinemia because this primarily just affects B cells, whereas T cells tend to be spared here, and so that's why they like to test that. Again, big point here, follicles, B cells, germinal centers are going to be very classic for activated B cells likely undergoing isotype switching. Classically going to see more of this in the setting of an infection, less of this with diseases that prevent B cell maturation. Now, paracortex, so think about, if you're just looking at this image here, right, so this is kind of the cortex that we talked about, and you can see here would be, a secondary follicle, here would be a primary follicle potentially, and then there's an outer cortex out here, which is kind of what we were just looking at. The inner cortex, though, would be this region closer to the medulla. That's staining a bit lighter here on this image. And that inner cortex is sometimes called the paracortex, okay? And that's where the T cells are going to be located. So paracortex, T cells, follicles are in the cortex, and that's where we'll have the B cells. Okay, so paracortex, we have structures similar to the periarteriolar lymphatic sheaths. We have the high endothelial venules. Okay, and this essentially allows lymphocytes to enter the blood. And let me just kind of walk you through this. So again, you want to think about if you were a cell or bacteria potentially coming into a lymph node, right? You're going to come in through the artery, and then there's going to be some capillaries that aren't really well depicted here. So let's draw them in. So there's some capillaries. Okay, so you might have some capillaries running through this area around the paracortex and the medulla potentially, right? Okay, so let's just blow this up with a cross section. So let's just say that here's my post-capillary venule. We're blowing it up. And, normally these venules will have endothelial cells. Okay, so I'm just going to draw some endothelial cells that surround the capillary. In these situations in the lymph node, sometimes we'll have these kind of gaps in here between some of the cells. Okay, so we might have some gaps there, might have some gaps here, might have some gaps here. Let's just say I had a T cell here, right? A couple T cells here. Okay, they're inside of my blood vessel. When they're coming through here, right, they came in through this artery and they want to go into this lymph node. They want to go into the paracortex. Maybe they have an antigen that they want to present to a B cell potentially to allow class switching to occur. Okay, so these T cells are coming in hot, right? Maybe they have an antigen and they need to get here as soon as possible. So what they can do is, instead of them kind of going through, the venous side and eventually getting the lymphatic circulation and getting over to the lymph node, they can just cross over through these venules and get into the lymph node, particularly into the paracortex. So that's essentially what's happening here. So these T lymphocytes can kind of jump through, you can think of them as little spaces in between the wall, allowing the T lymphocytes to just get into the lymph node directly. Okay, so that's what they're there for. And these again are called the high endothelial venules. I'll circle it here. HEVs. And remember, those are in the paracortex. Now remember, the T cells, we'll talk about this in great detail, very much associated with viral and fungal infections. So if you had a viral or fungal infection, you would see a pretty significant increase in the density of the paracortex in general. You might see some paracortical hypertrophy. Now, DeGeorge syndrome, remember, we talked about thymic aplasia, third pharyngeal pouch. Remember that. That's associated with DeGeorge syndrome. Now, if you had thymic aplasia, remember, the thymus is where the T cells mature. If you don't have mature T cells, you're going to have paracortical atrophy, right? You're going to have the opposite. Just like if we said, if you don't have mature B cells, you're going to have atrophy of your follicle. So just kind of, this is where you put all of the pieces together by understanding where these cells are from. Okay, so that's the multi-step integration and what we're talking about. Okay, finally, last thing here, the medulla. Again, that's going to be this inner layer. You're going to have your sinuses here. Here you'll see plasma cells, lymphocytes, macrophages. The idea here is, right, we're bringing in this blood. Eventually, this blood is going to come out through our venous system. It's going to come out through an efferent vessel. And then we also have lymph coming in through afferent vessels and then leaving through efferent vessels. Okay, so we have lymph coming in through lymphatic vessels, and that lymph coming in is going to bring in lymphocytes, antigens, but we also have cells coming in from the arterial side, and that's all essentially getting mixed here. Let's just say that we have a B cell here. Okay, so we're just going to say we have some B cell. All right, so our B cell is going to run in to an antigen. Okay, so maybe we have a bacterial infection, and maybe there's an antigen from that bacteria floating around in the blood, and that antigen is going to run into smack dab into our B cell in the bloodstream somewhere. Okay, so this is all going to be happening in the bloodstream. And let's just say that this antigen has the same epitope as the B cell receptor, and we'll talk about all of that in a minute. But let's just say that that's the case. Essentially, let's just say that these guys are a match. So the B cell, what it will do is it might get activated, potentially. Okay, so this B cell might get activated. Let's put an orange circle around it. This is indicating that our B cell is now activated. So once this B cell is activated, one thing that it can do is it can turn into a plasma cell. Okay, so it can turn into a plasma cell. And plasma cells, you can think of them as factories for antibodies. So it can just pump out a bunch of antibodies against this bacteria, hoping that this antibody runs into that bacteria that had this antigen and then attaches itself to the surface, allowing it to undergo complement-mediated destruction or phagocytosis, like we kind of talked about. So that's one thing. But what the majority of B cells will do is they'll end up going to the lymph node. And since this is an activated B cell, once it gets to the lymph node, it's going to start forming germinal centers. Now, you can imagine, like I said, there's this pale area here. That's going to be the activated B cells. And the activated ones are kind of pushing all the dormant B cells out of the way. And so that's why you get this clear center region, and then you have this dark dormant region around it, because all of the B cells that are not part of the party, essentially, right? They don't have that same antigen receptor. They're going to be on the outskirts, while all of the B cells in the middle, these are all kind of planning their defense from this antigen. Okay, and that's the germinal center that we talked about in the secondary follicles that are activated because they ran into this antigen in the blood. Okay, so that's where the majority of the B cells are going to go, in the lymph node. And that's where this activation comes from. Okay, so that's that secondary germinal center. Now remember what I said. Once you get into the germinal center, those cells will undergo isotype switching. So these B cells that are in here, in the germinal center, that are activated, those cells are going to be undergoing isotype switching. So what that means is now they can make other antibodies. So you might get some of the B cells in that germinal center maybe some of these B cells will start making IgG antibodies, for example, or IgE antibodies, right? Depending on what this antigen was, right? If it's a parasitic infection, we might need more of our IgE antibodies, for example. So that's all going to depend. Okay, so there's certain cytokines that will stimulate that. We'll talk about it. And this whole isotype switching is going to happen largely because of some interaction with activated T cells, okay, which we'll talk about, like I said, in greater detail. The idea is that you're also going to have T cells that are going to be floating around here in the bloodstream, right? So T cells can also potentially run into our antigen that's floating around in the bloodstream, right? It might run into that same antigen that can bind to it, and then these T cells might go on into this lymph node to stimulate the B cells to go isotype switching, which would form IgG, IgE, different isotypes here, IgA, etc. Okay, so that's going to happen because the T cell and the B cell will link up, and that will allow isotype switching to occur. And the specific markers that we talk about with this is going to be CD40 and CD40 ligand. Okay, and we'll go into more detail on all of this. But again, just to recap, we had a B cell in the bloodstream. It ran into some antigen. It went to the lymph node, then became very active in the germinal centers. We also had a T cell that ran into that same antigen. That T cell would also come into the lymph node, bind to that B cell. Okay, you have an interaction at a specific receptor, CD40 ligand. That's going to stimulate the isotype switching process to occur so we can turn our IgM antibodies into IgA, IgG, and IgE. Some of these B cells too might stay in the center here and form memory cells. Okay, so then if we ever get infected with this bug again, we would have cells already ready for it. Okay, so some of these B cells would form memory cells, and then some of these B cells here are also going to form the plasma cells that will undergo isotype switching that will create a host of different antibodies. Like I said, we'll go into all of this in much greater detail, but I just want you to have the framework for when we talk about the specific cofactors in the future. Okay, just to wrap this up here, Peyer's patches, just know that they're in the ileum, and know that if you had an antigen out here, that antigen, for it to get into this lymphoid tissue in the Peyer's patches, it would have to traverse this tissue via a specific cell type, and that cell type is the M cells. Okay, so that's important to remember. So the M cells allow the antigen to transport to the macrophages, to the antigen presenting cells, and then these B cells would eventually identify those antigens, right, that are in this lymphoid tissue. And you can see it kind of looks similar to the lymph node, right? You have this area in the center that looks very similar to that germinal center we just talked about. Okay, and so these active B cells would then go on to become plasma cells, plasma cell factories, and produce IgA. Whenever you have mucosal tissue, IgA is the antibody you want to think about. So particularly here in the GI system, so we sometimes call this the mucosal associated lymphoid tissue, the MALT. Okay, so just remember IgA, M cells, ileum, Peyer's patches, and then also just remember that the tonsils are also a secondary lymphoid organ. And these are the references for this video. I'll see you in the next one. Hey everybody, welcome to this end of chapter question. We'll give you 15 seconds to pause the video, read the question, and then we'll go through the answer and explanation. All right, so here we have a 22-day-old male with an uncomplicated prenatal history who's presenting to the emergency department with recent seizure activity and failure to thrive, okay? Vital signs reveal a temperature of 38.3 degrees Celsius or 101 degrees Fahrenheit. So this child has a fever evidently here. Respiratory rate is 72 breaths per minute and heart rate is 164 beats per minute. Now, one thing just off the bat here, you might be reading some of these and, especially if you're like in a testing environment, if you're not sure what a normal respiratory rate is or what a normal heart rate should be, especially in a 22-day-old infant, in these situations, a lot of the times, step one doesn't expect you to know the correct reference ranges for these things. And when you're in situations like this where you're starting to read this and you're like kind of panicking, okay, I don't know if this is normal or not, just kind of keep going in the question. Usually there's something that will kind of indicate what's going on. Now, we already know that, 101 degree Fahrenheit temperature is obviously not normal. So there is something going on here. So just kind of reading through this a little bit further here, physical examination reveals a harsh systolic ejection murmur at the left upper sternal border with a single S2. If you see an infant, especially, and they start to mention any kind of heart murmur, potentially you immediately want to start to think a little bit about congenital heart defects. So we'll kind of draw an arrow out here. You want to think a little bit about congenital heart defect. But let's kind of keep reading here and we'll kind of put this all together. So the initial labs that are done on this infant are significant for severe hypocalcemia. Remember, hypocalcemia in general is one of those electrolyte derangements that can potentiate seizure. Calcium supplementation and broad spectrum antibiotics are initiated. Okay, so the antibiotics probably because the child's febrile, and then again the calcium because they're hypocalcemic. Chest x-ray reveals cardiomegaly, right? That might have something to do with the murmur that we heard here, and an absence of a thymic shadow. So far in this question, there's a lot of, kind of non-specific things. An absence of a thymic shadow, though, remember, when you're talking about an infant in particular, remember, they're going to have a relatively large thymus. And remember, this chapter, we talked about the thymus being the site of T-cell maturation, right? So if there's an absence of a thymic shadow, that's suggesting that potentially this infant might not have a thymus, right? Because we would expect a thymic shadow or a sale sign, for example, is another term you might see when they're referring to the imaging findings in infants. Okay, so if there's no thymus, right, we're concerned about T-cell maturation. And in general, when you see an absence of a thymic shadow in an infant, especially in the setting of hypocalcemia, the first thing you want to be thinking about, right, no thymus, and you see hypocalcemia, the first thing you want to think about is going to be DiGeorge syndrome. Okay, in general, DiGeorge syndrome will very classically kind of present in this fashion. All right, and we'll talk about what DiGeorge syndrome is. There's a kind of a classic way to remember this, a mnemonic that's referred to very frequently as this catch-22, which I'll walk you through in a second. But before we do that, let's finish reading this here. So it looks like they did tracheal aspirate cultures that grew Enterobacter. Okay, so this child did have some form of infection. Over the following days, the infant develops pancytopenia and multi-organ failure with DIC. Unfortunately, despite numerous attempts at medical intervention, the infant will later expire. Okay, biopsies are obtained and reviewed. So the mediastinal soft tissue biopsies here failed to reveal significant parathyroid and thymic tissues, just like we kind of saw with the imaging findings, right? We said that there was an absence of a thymic shadow, and we're failing to reveal thymic tissue as well as parathyroid tissue, right? And so this is all kind of interlinked. The most important thing I want you to remember whenever you're doing any kind of board question, especially when you have kind of these like longer style vignettes that are becoming more popular, as you read through this, it's really easy to kind of, get a little nervous because you don't really know where this question's taking you. But the thing that you want to pay the most attention to is going to be the last sentence of the vignette where they're actually asking you a question, right? So here, lymph node specimens are most likely to reveal which of the following findings. So if we were to biopsy a lymph node specifically, right, that's the important part. We're biopsying a lymph node, what would we expect to see? We got to put the pieces together. First of all, we have to understand what's going on, right? And so there's some key things that you could take away from this to figure out what's going on. The first thing is there's an absence of a thymic shadow on imaging. The child presents with hypocalcemia and seizures and some form of infection. And we also did mediastinal soft tissue biopsies where we're not seeing any parathyroid or thymic tissues. So this is actually very classic for DiGeorge syndrome. So let's kind of walk through this. First of all, what's the problem in DiGeorge syndrome? The problem is we have a microdeletion, okay, a microdeletion on chromosome 22. And that's why we kind of remember this catch 22, because the deletion is on chromosome 22. Now, the problem here, what this does is essentially you have failure of the third and the fourth pharyngeal pouches to migrate, right? You have failure of third and fourth pharyngeal pouches to essentially go where they're supposed to go. And because of that, you end up with a hypoplastic or aplastic thymus, right? And the other problem is you can also end up with a hypoplastic or aplastic parathyroid gland, right? So your parathyroid gland can also be affected, right? And if the parathyroid gland is affected, remember the parathyroid gland is releasing parathyroid hormone, right, to maintain calcium levels, right? So if this is defective also, these patients can present with hypocalcemia, right? So we can presume that the hypocalcemia, it was probably the cause of the seizures in this infant. So the next question is, why did this infant expire from sepsis, right? What happened exactly here? Well, part of the reason could be because they had defective T-cell maturation. And typically, especially infants with DiGeorge syndrome, these infants will have recurring infections, right? Classically, they'll present with recurrent infections and they'll have a difficult time kind of fighting off these infections. Now, this is kind of a lot of detail here. Do you have to go into all of this detail to answer this question? You really don't. You just have to understand that this is DiGeorge syndrome, and the key thing that we talked about in DiGeorge syndrome that you'll see is paracortical atrophy. And you might be wondering, why in the lymph nodes would you see paracortical atrophy in DiGeorge syndrome? And remember, the paracortex, right? The paracortex in the lymph node is where we're going to have a lot of the T cell, right? And so if you have defective T cell maturation, right? We just said in DiGeorge syndrome, you have defective T cell maturation, right? This isn't working because you have a hypoplastic or aplastic thymus. Well, if you don't have the T cells here, the paracortex is probably going to have some degree of atrophy. You might be saying, well, wait a second, this infant had an infection. Wouldn't we see something like a reactive paracortical hyperplasia? In other words, wouldn't we see the paracortex kind of undergoing hyperplasia in the setting of an infection? Now, normally you can see this. The paracortex can undergo hyperplasia in the setting of an infection. That's because the T cells are going to be very active, when there's a viral infection or a fungal infection, and we have stimulation of cellular immunity, right? But the concept here is that if we don't have the T cells to begin with, then we're not able to fight off the infection, right? And so you're probably not going to have reactive paracortical hyperplasia. If anything, it's going to be most likely to be atrophy in the paracortical tissues. And this is, can vary in an infant. But in general, when you see DiGeorge syndrome, because the issue is with the T cells, you have to make the association T cells paracortex, right? So that you'll most likely have paracortical atrophy. If we had an adult patient that, had an infection, then we would expect to see some degree of reactive paracortical hyperplasia, especially if it was a viral infection, right? Or we had some cellular mediated immune response. Now, while we're here, let's just kind of go through these other options here. So underdevelopment of primary and secondary follicles. So the primary and secondary follicles are also in the lymph node. Now recall, the primary follicle, so I'll just put a 1 for primary follicle, this is kind of where the dense dormant lymphocytes will be. And when we're talking about the follicles in the lymph node, remember, these are primarily going to be B cells, right? So the primary and the secondary follicles will primarily hold B cells, right? That both the B and the T cells, they're going to kind of start in the bone marrow. But the T cells will go to the thymus to mature, whereas the B cells will mature in the bone marrow, right? So the B cells are not really affected by the fact that we don't have thymic tissue. They're going to be more affected if we had an issue with the bone marrow, right? Their maturation, at least, would be more affected if we had an issue in the bone marrow. So we shouldn't really expect to have any issues in the primary follicles or the secondary follicles. And again, recall that the secondary follicles are kind of composed of kind of two areas. So you're going to have a kind of dark staining outside to the secondary follicles, where you still have some of the kind of dense dormant B cells. And then the inside is going to be more kind of pale staining, and this is going to be your germinal center. And this is going to be where you have a lot of B cells kind of moving around here, very active. And for us to have underdevelopment of primary and secondary follicles, this would be more classic for a disorder that would affect B cells. And in DiGeorge syndrome, we're mostly just affecting the T cells. The other options on here, we have central lobular necrosis and massive sinusoidal congestion. This is really just really a distractor. This is more of something you might see in the liver. Now, it's possible you could make an argument that, well, maybe you'd see, sinusoidal congestion, you might see increased clotting factors, right? Because this child eventually, this biopsy happened after this child had DIC, potentially as a cause of death. But this isn't something that we, would classically see in the lymph node, at least. And then the last option on here, adipose tissue infiltration and hypocellularity. When you see adipose tissue infiltration and you start to see low degree of cell lines, you're thinking about something that, we'll talk about a little bit in the hematology section with the bone marrow specifically, where you can get like a myelofibrosis or an aplastic anemia, for example. But this would not be, very classic for, the lymph node in general. But again, more classic for a myelofibrosis or an aplastic anemia. Right? And this is going to be something that we see in the bone marrow specifically, usually not in the lymph nodes. Let's kind of wrap this up, just going through this catch-22 mnemonic. If you had trouble identifying that this was DiGeorge syndrome, one thing I want you to remember, when you're just memorizing catch-22 and all of these different acronyms and, easy ways to remember things, what we're writing here for this catch-22 is kind of hard to integrate into a vignette. So let me give you an example, right? So if I put, okay, C stands for cardiac anomalies, right? Well, you can remember cardiac anomalies, but you also have to understand how does that present in a question, right? So the hard part is taking this and then understanding that, a harsh systolic ejection murmur, cardiomegaly, right? These things all kind of come together in a question, and you have to associate that with the fact that the C is cardiac anomalies, right? So the thing that I like to do is I like to look for the most important findings of the catch-22, and then the other ones I can kind of integrate as I'm reading the stem. Now, I don't think cardiac anomalies is the most important thing in DiGeorge syndrome, but you can see things like, ventricular septal defects, you can see atrial septal defects, you can see tetralogy of Fallot also is very classically associated with this. The other thing you can see here, the A is usually anomalous face or facial defects, like a prominent nasal bridge. This C down here, just kind of jumping here, is cleft palate. So a lot of these, you can see these kind of, facial anomalies here also. The key things that I really want you to understand are going to be the H down here, which you can put for hypoparathyroidism, or you can put hypocalcemia, right? Kind of go hand in hand here. And then the T here is going to be thymic aplasia. Now again, in a board question, how does thymic aplasia present, right? You got to kind of put the pieces together. Thymic aplasia might present with them telling you that there's an absence of a thymic shadow, or they might tell you that they did a biopsy and there's not significant thymic tissues. or they could just give you an infant that has recurrent infections in the setting of hypocalcemia or seizures, right? So again, it's just putting this catch-22 into a practical kind of vignette style question to make sense of it. Hey everybody, Dr. Reviso here. In this video, we're going to talk about